10 questions. CO2 transport and pulmonary circulation. Pause after each question if you need time to think. Let's go. Question 1. The chloride shift occurs because A. Chloride leaves the RBC in exchange for oxygen. B. Bicarbonate exits the RBC in exchange for chloride. C. Sodium enters the RBC. D. Potassium exits the RBC. Pause if you need to think. The answer is B. Bicarbonate exits the RBC in exchange for chloride. Here's why. Follow the sequence at the tissue level. CO2 produced by metabolism diffuses into the red blood cell. Carbonic anhydrase catalyzes CO2 plus water to form carbonic acid. Carbonic acid dissociates to hydrogen ion and bicarbonate. Now there is a problem. Bicarbonate accumulating inside the red blood cell creates an electrical imbalance. Negatively charged bicarbonate is building up inside the cell. If it simply stayed there, electrical neutrality would be lost, and further bicarbonate production would slow or stop. The chloride shift solves this. Bicarbonate exits the red blood cell through an anion exchanger protein, band 3 protein, in the red cell membrane. As each bicarbonate exits, a chloride ion enters from the plasma to take its place. Electrical neutrality is maintained. Bicarbonate continues to be produced and exported into the plasma, where it can be carried to the lungs in high quantities. Without the chloride shift, the entire bicarbonate transport system would grind to a halt. The chloride shift is an electrically elegant solution to a chemistry problem, allowing the body to transport far more CO2 as bicarbonate than would otherwise be possible. At the lungs, the reverse occurs. Bicarbonate re-enters the red cell. Chloride exits. The reverse chloride shift. Bicarbonate is converted back to CO2. CO2 is exhaled. Question 2. In systemic tissues, hydrogen ions produced during CO2 transport are primarily buffered by A. Albumin, B. Plasma bicarbonate, C. Deoxyhemoglobin, D. Oxyhemoglobin. The answer is C. Deoxyhemoglobin. Here's why. Every time CO2 is converted to bicarbonate inside the red cell, a hydrogen ion is produced. CO2 plus water becomes carbonic acid. Carbonic acid dissociates to H+ and bicarbonate. For each bicarbonate that enters the plasma, an H+ is left inside the cell. If these H+ ions were allowed to accumulate freely, the red cell would become severely acidic. Carbonic anhydrase activity would slow. Bicarbonate production would stop. CO2 transport would fail. Hemoglobin solves this, specifically deoxygenated hemoglobin. At the tissue level, hemoglobin has just released its oxygen to the cells. It is now in the deoxygenated T-state configuration. Deoxygenated hemoglobin is a significantly better buffer for H+ than oxygenated hemoglobin. It accepts H+ ions, binding them to amino acid residues, neutralizing their effect, allowing CO2 to bicarbonate conversion to continue unimpeded. This H+ buffering by deoxyhemoglobin is not a coincidence. It is the Haldane effect in action. The same event, hemoglobin releasing oxygen, simultaneously increases hemoglobin's CO2 carrying capacity and its H+ buffering capacity. One molecule doing two jobs simultaneously, precisely at the moment and location where both are needed most, the metabolically active tissues. Deoxyhemoglobin, the primary buffer for H+ produced during CO2 transport in systemic tissues. Question 3. Compared with the systemic circulation, pulmonary circulation normally has A. Higher pressure and higher resistance, B. Lower pressure and lower resistance, C. Lower pressure and higher resistance, D. Similar pressure but lower resistance. The answer is B. Lower pressure and lower resistance. Here's why. The pulmonary circulation is one of the most remarkable vascular beds in the body. It receives the entire cardiac output, the same flow as the systemic circulation. but it does so at dramatically lower pressures and resistances. Normal pulmonary artery pressures, systolic approximately 25 millimeters of mercury, diastolic approximately 10 millimeters of mercury, mean approximately 15 millimeters of mercury. Compare this to systemic pressures. Systolic approximately 120 millimeters of mercury, mean approximately 93 millimeters of mercury. The pulmonary artery systolic pressure is 1/5 of systemic systolic. Pulmonary vascular resistance, approximately 1 to 2 Wood units, or 80 to 150 dynes per second per centimeter to the 5th power. Systemic vascular resistance, approximately 10 to 20 times higher. How does the pulmonary circulation accommodate the same flow at such low pressure? Highly distensible vessels. Pulmonary arteries have thin walls with minimal smooth muscle. Recruitment. At rest, many pulmonary capillaries are collapsed or minimally perfused. As flow increases, additional capillaries are recruited. Total cross-sectional area increases. Resistance falls rather than rises. This low-pressure system protects the alveoli. High hydrostatic pressures would cause pulmonary edema. The right ventricle is designed for this low-pressure circuit, thin-walled, compliant, excellent for high-volume, low-pressure work. This is why right ventricular failure occurs in pulmonary hypertension. When pulmonary pressures rise towards systemic levels, the right ventricle was never designed to work against that resistance. Question 4. Which west lung zone normally has the greatest pulmonary blood flow in an upright patient? A. Zone 1. B. Zone 2. C. Zone 3. D. Equal in all zones. The answer is C. Zone 3. Here's why. West's zones of the lung describe the relationship between alveolar pressure, arterial pressure, and venous pressure, and how gravity affects blood flow distribution throughout the lung. In an upright patient, gravity creates a hydrostatic pressure gradient, highest at the lung bases, lowest at the lung apices. Zone 1, apex, highest in the chest, lowest hydrostatic pressure. Alveolar pressure can exceed arterial pressure, especially if alveolar pressure is elevated, as with PEEP. Capillaries may be compressed, minimal to no blood flow. This zone represents dead space, ventilated but not perfused. In healthy, spontaneously breathing patients at rest, Zone 1 is essentially absent. Arterial pressure is high enough to perfuse even the apex. Zone 2, middle. Arterial pressure exceeds alveolar pressure. Capillaries open during systole, intermittent flow, moderate perfusion. Zone 3, base. Both arterial and venous pressure exceed alveolar pressure. Capillaries are continuously open. Continuous blood flow throughout the cardiac cycle. Maximum perfusion. Gravity pulls blood toward the dependent portions, the bases in an upright patient. Zone 3 always has the greatest blood flow. This is why dependent positioning matters. In lateral decubitus position, the dependent lung has better perfusion. Zone 3 physiology. And why PEEP can create or expand Zone 1 by raising alveolar pressure, compressing capillaries, increasing dead space. Question 5. Which condition decreases oxygen utilization by tissues despite normal oxygen delivery? A. Carbon monoxide poisoning. B. Cyanide poisoning. C. Anemia. D. Pulmonary embolism. The answer is B. Cyanide poisoning. Here's why. This question tests one of the most clinically important distinctions in toxicology, the difference between impaired oxygen delivery and impaired oxygen utilization. Most causes of tissue hypoxia work by reducing oxygen delivery to cells. Anemia, not enough hemoglobin to carry oxygen. Pulmonary embolism, disrupted gas exchange. Carbon monoxide poisoning, hemoglobin occupied by CO, unable to carry oxygen. Left-shifted curve. In all of these, the problem is getting oxygen to the cells. Cyanide is completely different. Cyanide inhibits cytochrome C oxidase, complex 4 of the mitochondrial electron transport chain, the final enzyme in aerobic respiration. Oxygen delivery to the cells is completely normal. Oxygen arrives at the mitochondria normally, but the cells cannot use the oxygen. The electron transport chain is blocked. ATP production ceases. Aerobic metabolism stops. The cells switch to anaerobic glycolysis, producing massive amounts of lactate, profound lactic acidosis. This is histotoxic hypoxia, toxic to the cellular machinery that uses oxygen, despite normal delivery. The clinical signature, venous blood, is bright red, the same oxygen saturation as arterial blood, because the tissues could not extract oxygen from the blood that passed through them. Elevated venous oxygen saturation with severe lactic acidosis in a critically ill patient. Think cyanide. Treatment: hydroxycobalamin binds cyanide directly, or sodium thiosulfate plus sodium nitrite. Delivery is fine. Utilization is the problem. That is the defining feature of cyanide toxicity. Question 6. Which enzyme is found in high concentration within red blood cells and dramatically accelerates CO₂ transport? A. Carbonic anhydrase. B. Acetylcholinesterase. C. Catalase. D. Cytochrome oxidase. The answer is A. Carbonic anhydrase. Here's why. The conversion of CO₂ in water to carbonic acid, CO₂ plus H2O, to H2CO3, can occur spontaneously in plasma, but spontaneously, it is extraordinarily slow. Left to proceed without a catalyst, it would take several minutes for equilibrium to be reached, far too slow to occur during the fraction of a second that blood spends in a systemic capillary. Carbonic anhydrase accelerates this reaction by a factor of approximately 5,000 to 10,000 times. A reaction that would take minutes happens in milliseconds. This allows the entire CO₂ to bicarbonate conversion cycle, CO₂ entry, carbonic acid formation, dissociation to H+ and bicarbonate, bicarbonate export, chloride shift, to complete within the brief time blood transits a tissue capillary. Without carbonic anhydrase, CO₂ transport as bicarbonate would be negligible. The dominant form of CO₂ transport in the body would not exist at its current capacity. Carbonic anhydrase is concentrated inside red blood cells, not in plasma, which is why the reaction primarily occurs inside the RBC rather than freely in the plasma. Clinically, carbonic anhydrase inhibitors like acetazolamide block this enzyme. Reduced bicarbonate formation, metabolic acidosis, diuresis used in altitude sickness, glaucoma, and certain types of edema. Carbonic anhydrase, the enzyme that makes CO₂ transport physiologically possible at the speed of life. Question 7. In systemic tissues, bicarbonate leaves the red blood cell in exchange for A. Potassium, B. Sodium, C. Chloride, D. Calcium. The answer is C. Chloride. Here's why. This is the chloride shift, already established in question 1, but tested again here from a slightly different angle. As bicarbonate is produced inside the red blood cell at the tissue level, it must exit the cell to be carried in the plasma. Bicarbonate is negatively charged. If it simply leaked out, the red cell would develop a positive charge. Electrical neutrality would be lost. The anion exchanger, band 3 protein on the red cell membrane solves this by simultaneously moving one chloride ion in for every bicarbonate ion out. Both are negatively charged anions. One in, one out. Net charge unchanged. Electrical neutrality maintained. This is a 1-for-1 exchange. Chloride in, bicarbonate out. At the lungs, the process reverses exactly. Bicarbonate re-enters the red cell from the plasma. Chloride exits. Bicarbonate is reconverted to CO₂ via carbonic anhydrase, running in reverse. CO₂ diffuses into the alveolus and is exhaled. The chloride shift at the tissues loads CO₂. The reverse chloride shift at the lungs unloads CO₂. Bicarbonate out, chloride in. At the tissues, every time. Question 8. A patient receives excessive PEEP during mechanical ventilation. Which pulmonary zone is most likely to expand? A. Zone 1. B. Zone 2. C. Zone 3. D. None of the above. The answer is A. Zone 1. Here's why. Return to West's zones. Zone 1 is defined as the region where alveolar pressure exceeds both arterial and venous pulmonary pressures. When alveolar pressure exceeds arterial pressure, capillaries are compressed by the surrounding alveolar pressure. Blood cannot flow through. The region is ventilated but not perfused. This is dead space. In a healthy, spontaneously breathing patient, Zone 1 barely exists at rest. Pulmonary arterial pressure is high enough to perfuse even the lung apex. But when you apply excessive PEEP, alveolar pressure rises throughout the lung. At the lung apex, already the zone of lowest hydrostatic perfusion pressure, the increased alveolar pressure is most likely to exceed the local pulmonary arterial pressure. Capillaries are compressed. Zone 1 expands. More of the lung becomes ventilated but not perfused. Dead space increases. This has two direct consequences. First, wasted ventilation. Minute ventilation is being delivered to regions that cannot contribute to gas exchange. CO₂ elimination becomes less efficient. PaCO₂ rises unless minute ventilation is increased. Second, increased right ventricular afterload. Compressed pulmonary capillaries increase pulmonary vascular resistance. The right ventricle must work harder, particularly problematic in patients with right ventricular dysfunction. This is why PEEP must be titrated carefully, enough to recruit collapsed alveoli and improve oxygenation, not so much that it creates dead space and compromises hemodynamics and CO₂ elimination. Question 9. Compared with the apex of the lung, the base has A. Higher V over Q ratio, B. Lower blood flow, C. Lower PO2 and higher PCO2, D. Higher PO2 and lower PCO2. The answer is C. Lower PO2 and higher PCO2. Here's why. This seems counterintuitive at first. The base has more ventilation than the apex, so why does it have lower PO2 and higher PCO2? The key is V over Q ratio, ventilation divided by perfusion. Both ventilation and perfusion increase from apex to base in an upright patient, but perfusion increases much more dramatically than ventilation does. At the apex, ventilation is reasonable, but perfusion is very low. V/Q ratio is high, approximately 3 or more, relatively more ventilation than perfusion. Gas exchange is excellent per unit of blood flow, high PO2, low PCO2 in apical alveoli, approximately PO2 130 millimeters of mercury at the apex. At the base, both are higher, but perfusion increases far more than ventilation. V over Q ratio is low, approximately 0.6, relatively more perfusion than ventilation. The high blood flow means each unit of ventilation is serving a much larger volume of blood. That blood extracts more oxygen and delivers more CO₂ than the ventilation can fully remove. Alveolar PO2 at the base, approximately 89 millimeters of mercury. Alveolar PCO2 at the base, approximately 42 millimeters of mercury. Overall arterial blood is a mixture of blood from all zones, and the base dominates because it receives so much more of the cardiac output. The high V/Q at the apex, very efficient gas exchange per unit blood flow, but very little blood is there to benefit from it. The low V/Q at the base, less efficient per unit blood flow, but vast amounts of blood are passing through, dominating the composition of arterial blood. Question 10. A patient breathes 100% oxygen, yet arterial PO2 remains severely reduced. This finding is most consistent with A. Hypoventilation, B. Diffusion limitation, C. Right to left shunt, D. High altitude. The answer is C. Right to left shunt. Here's why. This is one of the most clinically important and board-tested concepts in respiratory physiology. When a patient breathes 100% oxygen, alveolar PO2 rises dramatically to approximately 650 to 670 millimeters of mercury at sea level. In essentially every cause of hypoxemia other than shunt, this dramatically elevated alveolar PO2 drives enough oxygen across the alveolar capillary membrane to substantially correct arterial hypoxemia. Hypoventilation, low alveolar PO2 from inadequate minute ventilation, supplemental oxygen directly raises alveolar PO2, corrects hypoxemia readily. Diffusion limitation, thickened membrane slowing oxygen transfer. The massive increase in alveolar capillary oxygen gradient from 100% oxygen overcomes the diffusion limitation, significant improvement. High altitude, low inspired oxygen fraction. Supplemental oxygen directly replaces the missing oxygen, corrects hypoxemia. Right to left shunt. The shunted blood never sees the alveoli. You can make alveolar PO2 as high as you want, 650 millimeters of mercury, 670 millimeters of mercury. It does not matter. The shunted blood bypasses all of those beautifully oxygenated alveoli entirely. It arrives in the left heart and systemic arteries still deoxygenated. When it mixes with properly oxygenated blood, it drags down the arterial PO2, and no amount of supplemental oxygen can fully correct this, because you cannot oxygenate blood that never passes an alveolus. This is the defining clinical feature of right to left shunt. Hypoxemia refractory to high-flow supplemental oxygen. Think intracardiac shunt, pulmonary AVM, or severe atelectasis with complete alveolar collapse. That is 10 questions. CO2 transport and pulmonary circulation. Your 5 things to lock in before you go. Chloride shift. Bicarbonate exits the RBC. Chloride enters, maintains electrical neutrality, enables CO2 transport as bicarbonate. Deoxyhemoglobin. Primary H+ buffer at the tissues. Haldane effect. O2 release enhances CO2 uptake simultaneously. Pulmonary circulation. Low pressure, low resistance. Normal mean PA pressure, approximately 15 millimeters of mercury. Right ventricle is not designed for systemic pressures. West zone 3. Greatest blood flow in upright patient. Gravity increases perfusion at the lung bases. Right to left shunt. Hypoxemia refractory to 100% oxygen. Shunted blood bypasses alveoli entirely, the defining clinical feature. I'm Anesthesia Buddy. Stay sharp. See you in the next one.